Dear colleagues, good afternoon. First of all, I want to thank the organizing and scientific committee, the presidium, and for opportunity to participate in this meeting for the second time in this beautiful and historically rich city. In the beginning, I want to highlight some epidemic aspects of HIV infection in Russian Federation. So, according to official data on the end 2018, the cumulative number of all reported cases of HIV was amount 1,300,000 people. And during the entire period of epidemic, about 300,000 people were dead. There is a tendency to diagnose new cases of HIV infection in the older age group. Also, one of the most affected group of patients is people of working age. And at the moment, sexual transmission is prevailed, and it is about 57%. On this slide, you see a number of newly diagnosed cases of HIV infection in the different years. And we have two peaks of HIV detection in Russian Federation in the beginning of the 2000s, and it's associated with consequences of injectable drug use. And the second peak was now in the recent years, and it is associated with the program of active HIV testing of population. And on the one hand, it seems that we have a positive tendency, but the number of cases don't take into account all the migrants and foreigners and anonymous persons. So most likely we are facing the highest point of HIV detection in the recent years. Women of reproductive age continue to be involved in the epidemic, accounting for 41%. In St. Petersburg, the huge work has been done for reduce the rate of parental transmission of HIV infection, and now it is 1.3%, compared in the 1995 it was about 20%. Due to the fact that cases of HCV infection began to be registered in Russian Federation in the late 19th, so we do not have sufficient data about the number of people living with this diagnosis, but perhaps it is about 5 and 8 million of people. As with HIV infection, we see an increase of sexual transmission of HCV infection, and also we don't have additional information about HIV-HCV co-infection and do not have specific data, but perhaps also it's about 50 to 90% of citizens. Young women with HIV and HCV co-infection are a special cohort of patients because of the potential of sexual transmission and infection of their child. So we decided to analyze this group of patients to identify their social, psychological, mental problems, comorbid diseases, and that can be affect to the treatment of HIV and HCV infection. We use a complex of clinical, laboratory, and instrumental methods on the sample of 191 women, including assessment of social and mental status, cognitive function, immune status, viral load of HIV and HCV, fibrosis degree, and etc. The median of women with co-infection was 35 years. More than half of them have a high or technical education. Most of them have jobs, were married and have children. Only 23 women were unemployed, and most of them citing to their own refusal. We conducted a survey of 100 women and identified the main social problems and classified to ICD-10. So most of women concerned about problems related to work and unemployment, and about 30% problems in family. The leading problems also included challenges related to the lifestyle or economic difficulties. We analyzed the narcological status of women and found that most of them are in remission of use uninjectable and injectable drugs, and more than 10 years. At that time, only 6 women active use drugs. In-depth psychiatric research we also revealed a number of problems. Most women have been treated in narcological hospitals in the past. More than half experienced anxiety, third of patients reported obsessive thoughts and phobias, more than 80% suffered from sleep disorders, 5% had clinical manifestation on depression, and 3% of women experience of suicide attempts, and mainly demonstratively black male type. We also wanted to assess the frequency and extent of negative impact of alcohol use between women. We used a comprehensive approach, analysis data, clinical examination, laboratory tests to determination of derivatives of alcohol in urine and blood, and instrumental methods. It turned out that about 90% of co-infected women reported drinking alcohol more than 2 times a week. 152 women have positive test of ethyl glucuronide, a marker of recent alcohol use, and 39 women with a negative result of ethyl glucuronide were analyzed for determination of carbohydrate deficient transferrin, a marker of chronic alcohol abuse, and the positive indicators was in 6 cases. More than 90% of women with co-infection received antiretroviral therapy, and 91% had undetectable viral load. Basically, they have a satisfactory indicators of immune status. HCV ANA was found in 169 women, genotypes 1 and 3 prevailed. Only 9 women received HCV therapy in the past, in one case with direct-acting drugs and other with combination pegylated interferon and ribavirin and simiprevir. According to the results of FibroScan, 90% of women have minimal signs of the fibrosis. The analysis of medical cards revealed that many women have confirmed comorbid condition. Among them are leading diseases of the digestive system, urogenital organs, and cardiovascular system. Our goal is to help women overcome social and psychological barriers, reduce stigmatization, increase the coverage of this patient of antiretroviral therapy and HCV treatment with achievement of favorable outcomes. We also continue to use a multi-steps and multidisciplinary approach. This includes the creation of online program and also brochure to increase patient awareness to their diseases. In the conclusion, I want to say that women with HIV and HCV infection co-infection has psychological and social problem, and they need additional support. maybe before starting HIV and HCV treatment. More than 70% of women have mental illness and disorders, problematic alcohol use, and it's necessary to include continuous monitoring and correction of the condition periodically. Also to prevent drug use relapses and reduce alcohol use. Most women try to alleviate the negative impact on their organism, and more women have high levels of adherence to antiretroviral therapy, and it is perfect background to start HCV treatment. Oh. And the last conclusion, 30–40% of women are diagnosed with comorbid condition. So they need additional in-depth examination and treatment for comorbidities. Also, we need to use a modern schemes of antiretroviral therapy to exclude the risk of polypregnancy. In a large numbers of cases, women with HIV, HCV co-infection have advanced liver fibrosis, and it is priority for HCV treatment. Given the psychometric status of the women with co-infection, using the DAS is a priority for this group of patients. Thank you for your attention.